session. I firmly believe that international exchange of the opinion like this session are extremely valuable for the further development of medicine. So I expected the audience's active comments and discussion. Okay, the first speaker is from our hospital, Japan too. Junichi Ayabe is now the experienced the many cases of IBR. Okay, so please start.
Thank you for introducing me. Nice to meet you. I'm from Yokosuka, Japan. Thank you for inviting me to this special conference in Vietnam. I'm honored to have the opportunity to present at such a wonderful event. This is a traditional craft in Japan. It is made by hand from multiple woods, not painted. Industrial products are moving towards simplified manufacturing. Sorry. The mouse is not working well. Okay. But manual, rather than automated, will still be an important factor in our treatment. Today, I would like to tell you, especially young doctors, focusing on the technical aspects about coil embolization and characteristics of coils. First of all, I would like to inform you of our relationship with Hue Central Hospital. We signed an agreement about interaction and personal exchange program at 10 years ago. Since then, this is first man neurosurgeon, Dr. An, and 10 doctors have trained at our hospital. And next, looking back at our treatment, starting with helical GDC coils, and various types of coils have been developed at the same time. Assist techniques are being evolved. In recent years, flow diverter stent, or web, and so on, other new devices have emerged to provide safer, more radical treatments. This was my first case to treat with endovascular surgery. It's 20 years ago. Coil embolization was performed for vaginal tip aneurysm. I had performed complete embolization using GDC coil. Through trial and error, I used many shorter coils. Nowadays, it is possible to use the web to provide more radical treatment for the bifurcated aneurysm. Or for large or giant aneurysm, flow diverter stents are effective. These treatments are safer and simpler. Although new devices are being developed, coil embolization plays a significant role in the treatment of cerebral aneurysm. I think the basic technique is important in any treatment. Here I have a question for you. Is a coil something that goes into the aneurysm by itself? Or is the coil something that is inserted in the aneurysm with our hand? The answer is that the coil does not go into the aneurysm by itself. We insert the coil in the aneurysm and prevent rupture by making coil mass. To insert the coil safely and obtain thrombosis reliably, fine manipulation is required. This is basic technique of endovascular therapy. Of course, in some cases, it is possible to insert a coil simply by pushing it, depending on the performance of the coil. This is MCA aneurysm. I use the axiom coil. This coil can be inserted into the aneurysm without the need for moving catheter. So finally, I can good embolization. On the other hand, when creating a coil mass, manipulation of catheter is required along with the performance of the coil. A 59-year-old woman suffered a cerebral infarction caused by a spasm. Left ICA large aneurysm was recognized. The video is not working.
Maybe you should log out and then
First, it's prediction model due to
all close and then you can this and yes and then now and use the result.
slideshow. Not working.
Use it more and then click the video. Or can type.
Cannot.
So use
But cannot work. So the first coil is placed roughly in the aneurysm. The second coil is intended to create a frame near the neck. For this plan, the catheter is controlled and moved forward or backward, depending on the behavior of the coil. Cannot play media. So the coil is carefully inserted loop by loop. It was able to form a coil mass near the neck and preserve the picon. As the coil is inserted, the catheter goes out in reaction. Press slightly when one coil loop rolled. Depending on the behavior of the coil and the catheter, we must finally control the microcatheter position. We need not only to push the wire, but sometimes to pull the catheter, or sometimes to push the catheter. The coil is inserted loop by loop, so we can insert the coil and make coil mass in safe. The coil mass are our products. But sometimes it is necessary not to move the catheter. The case is a 50-year-old man with SAH. I was diagnosed with left internal carotid aneurysm, blister-like aneurysm. How should I treat it? Recently, it may be a flow diverter stent placement. But to obtain earlier and more reliable thrombosis, I think a stent coil is preferable. These are the final images. The Elvis stent was placed. and dilated portion around the stent was filled with coils. ICA looked like normal just after procedure. And this video is not working. I want to show you a video of the stent being deployed, but I can't, so I explain it with my words. When the stent deployed, the catheter pulled back, and the microcatheter for aneurysm is moved, dragged out, or come back. If the catheter moves out the aneurysm, we can't reinsert the catheter to the aneurysm. So, not to move the tip of catheter, I must control the catheter. It is also kind of a technique. After placed stent, we must embolide the aneurysm. The coil that helps with this technique is the IED coil. The first coil is inserted using the semi-gel technique. The catheter moves slightly, but it doesn't come out. The third coil, that is final coil, is inserted using the gel technique with the stent already in place. It gets into the remaining space. So we can make coil mass in the dilated portion. Why IED coil is best for such situations? The IED coils are distinct from others with these aspects. Firstly, I would like to note that it has less kickback. The reason for the low kickback is the difference in SR structure. It's called wave SR suture. This differentiating feature gives the coil slack as it folds, minimizing microcatheter kickback. Another reason why IED have less kickback is the tip of delivery wire, so-called coil pushing a coil. The structure is coiled, so soft. This has tested how much it moves the catheter tip formed at 90 degrees moves. The tip of the IED pusher wire is the least movement. And IED complex silky soft is the lowest K factor. So this coil is most soft. Combined with the wave SR construction, delivery wire, the complex silky soft coil is the most flexible and least kickback. This is a case that was treated by taking advantage of the characteristics of IED coil. It was very small. The minimum diameter is 1 millimeter. Maximum is under 2. Using the balloon guiding and microballoon assist technique, IED 1 millimeter, 1 centimeter was inserted into the aneurysm. This is next day. The aneurysm was disappeared. Please note that the balloon is not used for neckplasty, but to support. Balloon is here. This balloon supports a microcatheter. I often use balloon guide catheter, such ruptured ICA aneurysm case. The balloon guide catheter can reduce blood flow so that microcatheter could be stabilized or stable. This is a case that was able to be treated safely due to the small kickback and a very soft coil. Another feature of ID is Anfini type. This has less memory and spreads evenly to the aneurysm. In addition, the primary coil diameter is a bit large, over 10 inch, and the coil length is long, which can increase the packing rate, or you can reduce the number of coils. It is a large aneurysm with bleb that was thought to be an impending rupture due to the sudden onset of headache. After the stent was placed, first coil was ID Anfini 4 to 8 mm, 15 cm. It spread evenly in the aneurysm. Total of 4 Anfini coils have obtained a good embolization. I would like to give you one thing to note about ID. Coil detachment system is monopolar PVA detachment mechanism. We must stab needle to patient for us. If you use a thin needle and stab a little to be gentle on your patient, you may not be able to detach. Use a minimum of 22 gauge and puncture at least 10 mm. I have told you about the technical aspects that I think about and practice in coil embolization. Essence of neuroendovascular surgery. This also applies to neurosurgery. Know the disease and the devices and your patient. Look well the entire monitor, not gazing at the lesion. Move finely the catheter and the wire. These are part of my presentation. Did you notice the description at the bottom? I didn't mention it, but I do a lot of treatment with a transradial approach. Finally, I tell you the transradial approach. But I can't explain with video, sorry. At first, 4 French sheath is inserted in radial and exchange to this case, 8 French balloon guiding catheter. And use Simon type catheter for inner catheter and introduce the left CCA and advance to the ICA. It's same to the femoral approach. Transradial approach is less invasive and reduces patient burden. Transradial approach is friendly and kind, not only for the patient, but for us. The hemostatic time is very short. Please try this approach. This is final slide. This is a Japanese lotus in the pond of a temple in Kamakura. And Jizo standing next to the pond. I would like to conclude this presentation by hoping that a good relationship between us will continue. Thank you so much. Think I'm on.
Thank you very much for Dr. Junichi Ayabe for sharing with us about the coiling application of the anarchism and also for the transradial approach. And if you have any Q&A, and will be at the end of the section. And now we move to the next speaker. I'd like to introduce
Interesting topic, especially we now has a lot of venous stroke and venous congestion. And I think we will keep the discussion after the session. It's will be a lot of questions for you,
Okay,
for sure,
okay.
especially from my.
Okay, okay, okay. Thank you, thank you.
Okay, for the next talk, I would like to invite next speaker, Dr. Jaya Mahadevan from Kuala Lumpur with the presentation principle of treatment of neuro IVF. She, the former president of AIF RTN.